If food feels like getting stuck on the way down, your body may be warning you about something important. Difficulty swallowing is not just annoying, it can sometimes signal a nerve problem, a blockage, a reflux damage, or even cancer. Are you coughing when you eat? Needing extra water to swallow? Or feeling food stuck in your chest? Let's talk about dysphagia. Many people ignore swallowing trouble for months, but sometimes dysphagia is the first clue to a serious medical problem. Hello, everybody. I'm Dr. PK. Let's talk about dysphagia, which means difficulty swallowing. It can happen with solid, liquid, both. Some people feel like food gets stuck in the throat. Others cough, choke, feel pain when swallowing. Yesterday, I have a patient in his late 60s who showed up in the ER because of chest pain, and he had been having this swallowing issue for quite a while. Of course, everything was fine. He was sent back to me, and now he's gonna have upper endoscopy for that. So dysphagia is important because it can lead to dehydration, poor nutrition, choking, food or liquid going into lungs, which raises the risk of aspiration pneumonia. What is dysphagia? Swallowing looks simple, but it actually involves a complex process involving mouth, teeth, esophagus, nerves, muscles. If any of that system is not working properly, swallowing becomes difficult. Dysphagia may be mild and occasional, or it may become progressive and serious over time. There are different types of dysphagia. We're going to talk about that. Number one is oropharyngeal dysphagia. This means you have a trouble starting the swallow. The problem is usually in the mouth or throat. People say cough. People may have coughing, choking right after trying to swallow. They feel food is going down the wrong pipe, and they have nasal regurgitation. They need repeated swallowing to clear food. Have a wet or gurgly voice after eating. That's oropharyngeal dysphagia. This type is often related to stroke, Parkinson's disease, dementia, neurological disease, muscle disorder, or structural problems in the throat. Number two is esophageal dysphagia. This means swallow starts okay, but the food feels like it sticks in the chest or lower throat after swallowing. Common causes are GERD related inflammation or narrowing, esophageal stricture, Schatke ring, esophageal eosinophilic esophagitis or eosinophilic esophagitis, motility disorders such like echinacea, esophageal cancer, or other kinds of blockage because of polyps or other issues. The classic clue is difficulty with solid first, then followed by difficulty with liquid. It can suggest a mechanical narrowing, trouble with both solid and liquid from start. That suggests motility disorder. Functional or intermittent swallowing symptom. Sometimes symptoms come and go, and there is no major blockage. Um, it could be because of reflux, esophageal spasm, effective medication, anxiety around swallowing, or mild motility problems may play a role. And this still needs to have medical evaluation when persistent. So, warning signs that need urgent attention. And please do not ignore dysphagia if you have unintentional weight loss, progressive worsening, pain with swallowing, vomiting, regurgitation, coughing or choking repeatedly, food impaction, hoarseness, blood, new symptoms in older adults, trouble swallowing with neurological symptoms like people with a stroke, signs of aspiration such as fever, coughing during meals, or recurrent chest infection. So common causes of dysphagia, neurological, you got a stroke, Parkinson, dementia, multiple sclerosis, ALS, other nerve or muscle disorder. A structural causes is stricture, tumor, webs, rings, enlarged thyroid gland which pushes from outside, or external compression from any tumor from outside, Zenker's diverticulum, inflammation or infection. Motility causes achalasia, diffuse esophageal spasm, scleroderma related swallowing dysfunction. Inflammatory causes GERD, eosinophilic esophagitis, and piloesophagitis. Piloesophagitis, we see the patient who take medicine like alendronate, fosamax, actonel. Radiation related injury, that's inflammatory causes. So how do we diagnose dysphagia? First of all, diagnosis starts with a history. Is it solid, liquid, or both? Is it hard to start swallowing, or does food get stuck later? Is there coughing, choking, weight loss, pain, reflux, agitation? Now, this history helps guide what to do next. So there are some bedside swallowing evaluation. We don't really do it that anymore, but in the hospital patient, they usually do it. Often done first if there's an oropharyngeal dysphagia suspicion. It may be performed by a clinician or usually by a speech language pathologist. Video fluoroscopic swallow study called modified barium swallow. This is very helpful for mouth or throat swallowing problem. It shows how food and liquid move during swallowing and whether aspiration is occurring. Flexible endoscopic evaluation of swallowing is called FEES, F-E-E-S. A small camera is used through the nose to directly look at the throat during swallowing. It is another important test for oropharyngeal dysphagia. Upper endoscopy called EGD is commonly used with esophageal dysphagia and is suspected. It can find inflammation, stricture, cancer, eosinophilic esophagitis. Sometimes it can treat the problem during the same procedure. There's a stricture they can also do the dilatation. Barium esophagogram is really useful for looking at the structure and movement of the esophagus, especially if narrowing or motility disorders are suspected. Then there is esophageal manometry, and that measures the muscle contractions, pressure in the esophagus. It helps to diagnose achalasia and other motility disorder. There are some other tests like a pH testing, biopsies, and other kinds of imaging and lab work depending upon the suspicion, the initial part of differential diagnosis. Treatment of dysphagia: for oropharyngeal dysphagia, swallow therapy with speech language pathologist, safer swallowing techniques, positional changes, texture modification of foods, thicken liquids in selected cases, exercises to improve swallow function when appropriate. For reflux-related inflammatory causes, treat GERD, avoid trigger food, don't lie down right after eating, use acid suppression when appropriate, and treat eosinophilic esophagitis when present. For narrow or blockage, endoscopic dilatation, removal of impacted food, treatment of underlying lesion. For motility disorder, that treatment depends on disorder. Achalasia may be managed with procedure or surgery. Sometimes achalasia can be managed by Botox injection. I had a patient who had a long-standing problem with swallowing, leading to severe anxiety and magnesium deficiency. She ended up seeing a GI in Stanford, and she had a few procedures where she was injected with the Botox, and she was basically cured. Now every few months she goes there to get Botox injection. In the next video, I'm going to be talking about some more practical aspect of dysphagia, so watch for that video. Thank you for watching. I'm Dr. PK from Dr. PK Life. We'll see you next video.